Today, we will be discussing adult home health physical therapy. Some of the topics that will be addressed in this presentation include what is home health, common populations and diagnoses treated in adult home health, as well as documentation, billing and reimbursement, current policy issues, and many other hot topics in adult home health. So let's get started. Home health care is defined as skilled therapy services in the patient's place of residence. However, as per the home health section, home care may actually be provided in other places, including the caregiver's home, a hospital emergency room, skilled nursing facility, residential facility, group home, hospice, or elsewhere in the community. While the majority of patients are senior citizens, there are also pediatric patients with developmental disabilities and other conditions, which will be further addressed in the pediatric home health presentation. Home health physical therapy services are usually reserved for patients who are unable to leave the house to attend PT. 3 reasons a patient might be unable to leave the house to include 1. If their condition is acute or severe and leaving the home presents a health risk, 2. The patient's functional mobility is limited and they cannot travel to therapy, or 3. They lack adequate transportation or access to transportation to get to physical therapy.
So geriatric patients are the most commonly seen groups in home health, with an increasing rate of usage the older the patient group is, and in all patient groups, females tend to use home health more than males. Some of the commonly seen diagnoses are chronic conditions such as circulatory and heart disease like hypertension, also connective tissue diseases such as osteoarthritis, and then respiratory and cancer are other commonly seen diagnoses in home health.
Due to PT being the only healthcare provider in most situations of home healthcare, there are essential skills that are needed in order to keep the patient safe. The first one being able to complete accurate vital signs, including temperature, heart rate, respiratory rate, blood pressure, O2 saturation, orthostatics, and lung sounds. You can use these to document progress, linked to function, activity tolerance, recovery time, and is an objective measure. It is also wise to teach the patient about self-monitoring with RPE. The next skill will be a pain assessment, knowing if the pain is dull, achy, where the pain is, when it occurs, and how often, alleviating and aggravating factors, and if they take medication to help or any non-pharmacologic. You then will want to do skin assessments, and the goal is to identify any pressure ulcers. Determine if there are other lesions or factors that predispose pressure ulcer development. It's important to always explain what you are doing. If you see a significant change in a patient, you may need to look at their medications, making sure that they are taking their doses properly. Beer's List is a guideline for elderly and what medications they should avoid. Since these patients may not have a lot of outlets and you may be the only person they see, it is important to educate the patients to take an active role in their health and empower them to self-monitor their health with things like a journal. Due to the nature of home health care, it is difficult to manage normal equipment that you would see in an outpatient clinic. These are pieces of equipment that are smaller and easier to handle and travel with, and usually the most important ones that you would use. But most of the equipment will be made with the patient's own furniture and what they have available to them.
For documentation in home health, the most important thing to note is that your documentation often follows Medicare requirements, because a lot of the patients that are receiving home health care are geriatric patients that are covered by Medicare. Further, it's important in your documentation to document the medical necessity. You need to include why this patient needs home health physical therapy. This is especially important because as the PT, you might be the lone provider of care. You do not have quick access to a medical facility or other medical staff, and so your documentation truly needs to reflect why this patient could benefit from home health physical therapy as opposed to other settings, and you may be the only person to document this. Further, of course, your documentation really needs to reflect the need for skilled care. And of course, like documentation in any other setting, it's important for you to include all components of a SOAP note. And from what I have gathered from interviews with home health physical therapists is that their documentation is typically more comprehensive than in other settings. Another piece of your documentation that you may have to consider if you are a home health physical therapist is something called OASIS. OASIS stands for Outcome and Assessment Information Set. So one of the goals of the Center for Medicare and Medicaid Services is for their patients to receive quality home health care. So they created something called OASIS, which is a data collection tool, and its main purpose is to measure the performance of home health agencies. So all Medicare certified home health agencies must be providing data to OASIS. OASIS can then use this data to help guide quality and performance of Medicare certified home health agencies. So if you are a PT in one of these agencies, you will be responsible for adding your piece to OASIS. So that would be something you would have to do in addition to your documentation that you do for a daily session or for an exam.
Home health requires unique communication with other health professionals. Since you're not meeting in an office space on a consistent basis, then it requires you to be more intentional in the way that you communicate with other healthcare providers, such as other PTs, your PTAs, physicians, patients, and then other team members like OTs or your supervisors. So this can be done via phone call, video conferencing. Fax and email is very popular to do with physicians for referrals, plan of care, and discharge summaries. It also requires you to do visit collaborations or co-treatments if that be necessary for your patient. And so you would have to coordinate your schedules or also coordinate with a translator if that is also necessary. And then it's common to also have things called case conferences, which is where you meet in person with your team member or your supervisor, and it's just a schedule time so that you can discuss corporate changes or specific cases that you have. So this would be more like a regular team meeting. As far as for billing and reimbursement, you have your same codes that you typically do, so your ICD-10 and your CPT codes. They also established a National Correct Coding Initiative, which was to help with mistakes that were being made for Medicare Plan B. And then they also have home health conditions of participation, which are Medicare requirements of the administration and revision of the OASIS outcome measure. And so you have to do it every certain number of days or with a significant change in condition or discharge. So those are required to be reimbursed for Medicare. And then you also have your pay for reporting performance requirements, which is required in order to be reimbursed for fee for service, and those are based off of quality assessments.
Okay, in terms of payers in home health care, Medicare is the main payer. Medicare Part A pays for a lot of the home health care that our patients receive. It's a prospective payment system. What that means is it's one fixed payment for 30 days of care, and they determine that payment based on the patient-driven groupings model. Basically what this does is it places patients into payment groups based on their characteristics from 5 different categories. These categories are admission, where did they come from? So did they come from an institution like a SNF or community admission? Timing, is it the first 30 days of care or the last 30 days of care? Clinical grouping, so the main reason that they are receiving home health services. Functional impairment level, which is determined by the OASIS outcome measures. And comorbidity adjustment, and based on any other conditions that they have. Then Medicaid and Medicare Part B provide episodic payment, so it's based on each time that you see the patient. Then managed care, they are going to operate on either episodic payment or fee-for-service. Private insurers, it kind of varies, but they tend to be fee-for-service or episodic. They don't pay 100% of the cost to the patient. So Medicare Part A, they cover 100% of the cost to the patient as long as the certain requirements are met. So the patient must be confined to the home, currently under the care of a physician. Their plan of care must be periodically reviewed or updated by the doctor, and they must be in need of skilled nursing, PT, or speech on an intermittent basis, or have continuous need for occupational therapy. Medicare Part A also covers maintenance care, and there are a couple of variations. Partial episode payment, if they start home health care with one company and then switch to another company, they split that fixed payment. Low utilization is if the patient is seen 4 times or less. And then Medicare Part B is fee-for-service and covers 80% of the cost to the patient.
So there are 4 bills currently in legislation that we should be aware of. The first one is the Preventative Home Visit Act, which provides preventative home visits one time every 2 years for home assessment to identify health risks and provide referrals for interventions and modifications in order to improve physical activity, reduce fall risk, and provide nutritional guidance. The second bill is the Medicare Home Health Flexibility Act, which allows OTs to conduct the initial or comprehensive assessment for home health services in place of PTs or speech therapists if it doesn't require skilled nursing care. So basically, they would be taking part of our jobs, which could be a concern, but we'll see. The third one is the Home Health Payment Innovation Act, which waives home confinement requirements needed to receive home health services and alters payment methodology of behavioral assumptions regarding units of payment and case mix adjustment factors. So basically, more people will be able to receive home health and concurrently receive it. The last bill is the Home Health Care Planning Improvement Act, which allows home health services to be ordered by a nurse practitioner, clinical nurse specialist, and certified nurse midwife or physician assistant rather than just by a physician. So basically, more people will be able to prescribe home health, which increases the likelihood that a patient will be able to get home health. Currently, all of these bills are being looked by committee and have a very low chance of being enacted.
So as we know, PTs are generally responsible for the supervision of any PTAs, techs, or other staff members in a typical setting. The same is true for adult home health. However, with it being an off-site practice setting, the criteria becomes a bit more complex than we typically think of, just because everyone's not in the same building at the same time. In adult home health, PTAs can be treating patients when a PT is not directly present under what's called general supervision. And this supervision role is just dependent on a few factors: the complexity and acuity of a patient, proximity and accessibility to a PT, making sure supervision is available in the event of an emergency, and the type of setting the service is provided. There are certain requirements I have listed here that are put in place with the supervision of PTAs, and it's basically just saying that a PT can be accessible, and there will be conferences in place to determine the patient's needs and any change in care needed. Within the Texas PT Practice Act, they have several definitions of supervision laid out, and I have them listed here: PTAs, techs. Home health aides was interesting. They didn't explicitly state, but as long as they're not providing services deemed physical therapy, it's just going to be up to the PT or the employer. So basically what we know is true. PTs will perform the evals, revals, and discharges, and they'll assess and finalize any documentation, but a PT can perform daily treatments and assist in obtaining any objective or subjective data. Some supervision issues I came across were basically the number of PTAs allowed to be under the supervision of a single PT. Each state is going to have a predetermined level via the Federation of State Boards of Physical Therapy. You can also check out the state's PT Practice Act and talk with your home health agency to see any requirement as far as supervision level or other requirements noted. Fun fact on the next slide, there's actually a PT algorithm to help determine the appropriate direction and supervision of a PTA for optimal care. Other issues I noticed in the research: inefficient communication. This can be between multiple providers and the caregiver or patient, or just between the caregiver and the PT in general. So just making sure everyone's on the same page is going to be really key here. Inconsistent quality of care. We come across this in every setting, so just making sure our treatment is individualized for every single patient we have and to their best benefit. Home life and the safety of a PT. So if a patient's house is really cluttered, that could be detrimental to the PT as well as the patient if they try to do any treatment in the living room with a bunch of stuff laying around. Lack of appropriate caregiver training. I think our program does a really good job of making sure that we are really educating our caregivers as well as the patient to be able to produce this treatment when we're not there. Other things that are going to be talked about later: cultural differences, so stay tuned for that. And then lastly, inconvenient payment schedule. Just with it being home health, the payment schedule to the patient or the caregiver can be a bit tricky.
So here is the PTA direction algorithm. I know that it might be difficult to read this slide because the words are so small, but if you go to our references, you can follow the link to the APTA website for a clearer graphic. For now, I'll just give a basic overview of the algorithm. Once the PT completes the examination and evaluation, they must ask themselves a number of questions which are indicated in the red boxes. These questions are used to decide if a PTA can safely and effectively treat the patient.
These are the members of the APTA Home Health Executive Committee. They take part in research, government affairs, practice, and they are all liaisons to the Home Health Section committees.
The APTA offers an advanced competency program for home health, and it will review things that are pertinent specifically for home health practice, outcome measures, and regulatory requirements. There's also a pharmacology review, since we often conduct medication reviews with patients. It is not recognized by the Board of PT Specialists, meaning that it's not a credential that you get after your name, and you can't say you're a certified home health PT. You can only use the terminology saying that you've received a certificate of advanced competency in home health. The requirements are 40 contact hours total that have to be completed within 2 years of registration. There's 5 online courses and then 1 2-day face-to-face course. Students can register for the online courses, but they can't register for the face-to-face course or earn the certificate until they've received their PT license. Then there is an assessment that you have to take, and you have to pass with at least a 70%, and you get 2 attempts. And the cost varies, with the lowest cost being for those who are both APTA and Home Health Section members. And then the cost is slightly higher if you're just an APTA member, and it's highest for those who are not members of the APTA or the Home Health Section. Once you earn a certificate, you have to renew it every 5 years.
We can't talk about home health without talking about palliative care, hospice, and the importance of an advance directive. While palliative care is not the same thing as hospice, palliative care occurs through the lifespan, and hospice at the end of life. Both have the same objective: improving the quality of life of the patient and their family. Thanks in part to advances in medical care, Americans are living longer than ever before. While aging in and of itself is not a disease process, an increase in age comes with an increase in the prevalence and incidence of chronic diseases. Home health PTs can have a vital role in these patients' lives, working with them to manage symptoms and pain and reduce the stress from their chronic illness in their everyday lives through palliative care. PTs working with patients on hospice also work to ease their patients and their patients' families' discomfort at the end of their life. Home health PTs, and all PTs for that matter, should ask their patient if they have an advance directive, meaning a plan for their end-of-life care. Most Americans desire to pass away in their own homes, and having an advance directive makes it more likely for that desire to be realized. Unlike in other settings, home health PTs have to adapt to their patient's cultural setting and not the other way around. Home health PTs must recognize and respect the culture and beliefs of patients who allow us into their homes. Relating home health services to their culture serves to make the assistance more comfortable and familiar to the patient, less intrusive in the home setting, and more likely to gain compliance from the patient. As you all know from our other courses, building a therapeutic alliance with our patient is so important for their rehabilitation. That therapeutic alliance will be impossible to achieve if the patient is offended in their own safe space, their own home. That being said, initial assessment should include analysis of the specific cultural context of the home setting, along with the patient's cultural beliefs and practices related to their health and illness or ailment.
So a hot topic that was included in the Home Health Quarterly Report in 2019 is related to artificial intelligence and technological advances. So I just wanted to quickly put in here that this is kind of up and coming, but basically using computer science to do what we as people do now via algorithms. So currently there are several uses we use now that we see on a day-to-day basis, and there's many more to see in the future in the realm of home health as well as other PT settings. So just keep a lookout on that. The one thing I did want to point out is there are ethical concerns. Basically, in the future, if you are providing PT services and you have an AI program that you're using and your judgment is saying something different from what your AI program is saying, we are responsible for doing our best independent judgment in the patient's best interest. So just keeping that in mind with this coming up in the future.
Thank you so much for listening to our presentation on adult home health physical therapy. The Google Slides version without audio will also be available on the discussion board for download. Do you have any questions or comments? Has anyone had any experiences shadowing in home health or has talked to a home health physical therapist? Is there a specific topic related to home health that we didn't cover? If so, please post on the discussion board on campus. We look forward to reading and replying to your responses.